kind of aimed to give an epidemiologic overview of the outcomes of those who have cancer versus those who do not, who are hospitalized in the US with a diagnosis of acute respiratory failure. So hi, I'm Kian Heybati. I'm one of the third-year medical students at the Mayo Clinic.
My name is Hemang Yadav. I'm one of the pulmonary intensivists here in Rochester, Minnesota, and I'm a senior author on this paper.
Today, we're going to be discussing the outcomes of acute respiratory failure among those with cancer in the US, which is going to be published in the Proceedings April issue. So basically, to accomplish this goal, we looked at hospitalizations within the National Inpatient Sample Database. So briefly, this database contains up to 97% of all discharges from all payer kind of US hospitals. So we included all these patients between January 1st, 2006 to December 31st, 2018. Once we included these patients, we then broke them down based on a diagnosis of solid organ cancer, hematologic cancer, or without a cancer diagnosis. And to accomplish this, the NIS has specific diagnosis codes that have been validated and coded through the years. So this is all done with the prior literature in mind. Once we had this sample, we then figured out kind of how many people had different comorbidities, and then we also looked at different outcomes among this population. One key aspect of our methods was that we also aimed to see the outcomes among those who failed non-invasive ventilation. So what that means is initially when they were hospitalized, they received non-invasive positive pressure ventilation, and then were subsequently intubated using codes and procedure dates in the database. Lastly, we also weighted the samples to create population estimates. So in the database, there are specific population weights, which we can kind of extrapolate to the general US population and come up with specific population estimates. So overall, we estimated that during our, between 2016 and 2018, there was an estimated around 8.8 million admissions with acute respiratory failure in the US. And then we kind of categorized them and saw that around 9% had solid organ cancer, about 2% had hematologic malignancies, and the rest did not have an underlying diagnosis of cancer. Once we kind of broke them down into those with cancer specifically, around 30% required invasive mechanical ventilation, and then 10% had non-invasive positive pressure ventilation. We then broke them down to kind of look at the outcomes. So as expected, we saw that the in-hospital mortality was higher in those who had cancer versus those who did not. This difference was about twofold, about 24% versus 12%. And then we also stratified these based on the highest method of oxygen delivery. So we looked at among those who were invasively ventilated, non-invasive ventilation, and very little ventilation. And we kind of saw that this higher mortality persisted among the population. We also observed higher hospital length of stay among those who had an underlying diagnosis of cancer. We also saw that those who presented with a diagnosis of cancer were also more likely to fail non-invasive positive pressure ventilation. But of course, the estimates were more similar, so about 15% versus 13%. And then when we broke them down based on the type of cancer, those who had hematologic cancers generally had worse outcomes. In the paper, we also looked at associations between the cancer diagnosis and these outcomes after adjusting for age, sex, and different comorbidities. So once we did that, we also found specific factors that are associated with kind of these poor outcomes. So overall, basically what we saw that in our sample, around 10% of these individuals who are coming in with acute respiratory failure had an underlying diagnosis of cancer. They had higher mortality, specifically almost twofold higher mortality. And those who had specifically hematologic cancers experienced worse outcomes. However, kind of when we kind of compare this to the prior literature, we see that these rates have since improved, that the outcomes are improving. However, these individuals still face high mortality, high rates of healthcare utilizations and non-invasive ventilation failures requiring subsequent invasive mechanical ventilation. But of course, given that we looked at 2016 to 2018, we weren't able to actually analyze trends over time, which forms one of the limitations of the study, just because of how the database is coded. I'll also hand it off to Dr. Yetta for his insights on our results.
Thank you, Keenan, and great work on this paper. I think there's a few things I'd like to highlight about this paper. Firstly, the use of the National Inpatient Sample Database allows us to get a scale of national epidemiology of the problem, which is the burden of acute respiratory failure in patients who have cancer. And our main finding there is that every year in the United States, around 300,000 patients who have cancer are going to be hospitalized with acute respiratory failure, and that could be from pneumonia, heart failure, COPD, any of those diagnoses. And then of those patients who are admitted, a quarter of those patients will die in hospital. So that's a huge number, and that quarter is about twofold higher than patients who don't have cancer, and so that burden of mortality there on patients with cancer who have acute respiratory failure is very high. And the second part of this that is important is that that twofold mortality increase is there whether they have a DNR order in place or not. So it probably is not just an issue of ceiling of care or goals of care. It's probably because patients with cancer face so many other difficulties when they are hospitalized. They often have weakened immune systems in the context of chemotherapy, and they can have barrier dysfunction that makes them more prone to infection. And so our study really highlights the scale of the problem on a national level, and allows us to kind of essentially focus now on looking at why this increased burden of mortality exists in patients with cancer, and then work towards trying to mitigate some of that mortality in future studies. Thank you very much, and I'll hand it back off to Keenan in case he has any other comments here.
We invite you to delve deeper and look at the specifics of the article in the April issue of the Proceedings.
We hope you found this presentation from the content of our website valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you'll find access to information for our social media content, such as additional videos on our YouTube channel or journal updates on Facebook. You can also follow us on Twitter. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.